All right. We are going to piggyback right onto all the sort of fundamental stuff that we've talked about in terms of neuro over the past few weeks. Feels like it's been a few weeks. Has it really been a few weeks? I think so. And really start to talk clinically now about what we see in patients when we're starting to talk now about alterations in neurologic functioning. Today we're going to talk about alterations in not only cognitive systems, but also sort of the hemodynamics cerebrally. So chapter 14, here are your objectives for you. And really, up until this point in our discussion regarding neuro, we've talked a lot about motor systems and sensory systems, right? We've talked about how the information gets to the brain in terms of the sensory system, and then how we sort of answer that in terms of motor systems. But really, a person, or shall I say our patients, achieve functional adequacy or sort of competency in their world by really three complex neural systems. So motor, yes. Sensory, yes. But one thing we haven't really talked about so far is cognitive. So, how does the cognitive system sort of fit into the neurologic functioning that we've been talking about so far? So today we're going to focus a lot on that, especially at the beginning here of the lecture, on dysfunctions of the cognitive system. And really, when talking about the cognitive system, or shall I say alterations in the cognitive system, we really talk about consciousness, right, of our patients. And really what I mean by consciousness is the state of being aware of oneself and basically of that person's environment. And consciousness really involves two things. To be conscious, there's sort of two things that have to be achieved. And that is being aroused or arousal or arousable, and being aware or the state of awareness. And you may sort of hear those terms and think, yeah, okay, what's really the difference of those two? What makes one the other? Well, let's talk a little bit about what these definitions are and how arousal is quite different than awareness. So arousal is basically just the state of being awake, the state of wakefulness. And, as we discussed the sort of the different structures of the nervous system in one of those PowerPoints or the voiceovers while I was gone, I really discussed how wakefulness is really mediated by something called the reticular activating system. Okay? It really is the part of the brain that regulates attention, or being able to sort of hold attention, and information processing, right? So arousal is dictated or mediated by the reticular activating system. And the way I want to sort of have you think about it is that the reticular activating system is very primitive in terms of what it controls. So it does not control your higher level sort of cerebral activity. It doesn't allow you to be able to sort of solve math problems or write a paragraph or hold an intellectual conversation with someone. It literally just keeps you alive. It keeps you awake. It keeps your brainstem functioning in that you're breathing and you're taking in oxygen. It keeps your heart beating. It basically just keeps you awake. It's very primitive in terms of its function that it does for you or your patients. So when that higher level of cerebral functioning is lost, so let's say like the actual cerebrum, the tissue of the cerebrum has been damaged, either a traumatic brain injury or a bleed or something like that. When the higher level cerebral functioning is lost, it's the reticular activating system and the brainstem that really just kind of kicks in to be able to sort of maintain sort of that crude waking state. So in that being said, it is possible for someone to be awake or be arousable, but not really have that higher level cognitive functioning going on. Does that make sense? Okay. As opposed to the term awareness, which really is more of your higher level functioning. So this now is sort of referring to the actual content of thought. So the fact that you can actually form thoughts and have higher level sort of brain functioning. So really awareness encompasses all of those higher level cognitive functions. Awareness of self, awareness of environment, awareness of mood, being able to sort of interact with another human being, those types of things is awareness. So if you're going to think about one being sort of more higher level functioning than the other, awareness is certainly higher level functioning. Arousal just means your eyes are open. You could literally be arousable and be awake, right? But not really be aware of what's going on around you. Does that make sense? Yes? Okay. So those are the two sort of ways that sort of play into our cognitive sort of neurologic abilities, so to speak. And sort of going back to this whole arousal state, it's like, as I just said, it's totally possible for you to have no idea what's going on around you and not being able to interact with what's going on around you, but you to actually be awake and your eyes be open and maybe even tracking, things around the room. And we'll talk about this in a little bit in a few slides, but this truly is sort of like getting at that concept of like a vegetative state, right? You've heard that term maybe thrown around in the past, in that, someone may be awake but not really aware of what's going on around them. And we'll talk more specifically about that in just a second. So we're going to talk first here this morning about alterations of arousal and then alterations of awareness, because you can have a difference, right? You can have an alteration in one and maybe not the other. Okay, so let's talk first about alterations in this wakefulness, or the ability to be awake. Structurally, before we sort of get into this, true alterations of arousal, I want to sort of orient ourselves structurally and sort of geographically in the brain. So really, structurally, I want you to think of the brain as sort of divided above or below something called the tentorial plate. So actually, I'm going to skip to the next slide for just a second to sort of show you geographically of what I'm talking about. The tentorial plate is an actual fold of the dura mater that's sort of right here where you sort of have the cerebrum and then you have the cerebellum under that. The tentorial plate is really this fold of dura mater which separates the cerebellum from the cerebrum. And really it encloses sort of this plate of sort of part of the skull called the bony tentorium. So there's actually this little bony tentorium that folds down in here between the higher parts of the brain and the cerebrum and the lower part of the brain, like the cerebellum and the brainstem, okay? And the way I want you to think about this plate that sort of lies here, is that if you would continue to sort of extrapolate that line across sort of this cross-section of the head, that it sort of creates, as I sort of think about, kind of the Mason-Dixon line, so to speak, of the brain, right? Above it is north, below it is south, and above it is sort of the more higher level functionings that you'll get from the cerebrum. Below it is sort of your more reflexive, kind of primitive functions of the brain, like the cerebellum, or I should say the functions of things like the cerebellum and the brainstem. Does that make sense to you, geographically speaking? Above it is sort of your higher level of functioning abilities. Below it is more of your brainstem primitive kind of, being able to be awake, being able to breathe, being able for your heart to be beating. That's kind of the functions below that tentorial plate. Does that make sense? So, going back a slide, if you've got some sort of alteration above the tentorial plate, meaning, maybe there's some sort of inflammation in that area, maybe there's some sort of tumor or mass, like a neoplasm, maybe there's been a closed head injury with some bleeding in that area, as opposed to injuries that are below. Again, you can sort of see the same kinds of issues or the same types of injuries below that tentorial plate, but answer me this. If I have got some sort of traumatic brain injury or a bleed or something like that to some sort of structure above the tentorial plate, geographically speaking, what might you think you would expect to see in your patients, clinically speaking, in terms of their level of dysfunction, so to speak? Problems of awareness. Right, exactly. So in that respect, talk to me a little bit about their cognitive function, if there's an injury above that tentorial plate, like in the cerebrum itself. Mm-hmm. Right, higher level functioning problems. Right, good. As opposed to, if there's an injury below that tentorial plate, so let's say there's a brainstem injury or something like that, what kind of things are we really concerned about to an injury below the tentorial plate? What do you think? Yes, right, exactly. All those basic sort of functions of being alive, right? So clinically speaking, we as clinicians are very, very concerned about some type of injury below that tentorial plate, because that's where that primitive stuff is, the primitive functions are sort of housed. So if there's someone that has a pretty significant sort of brainstem injury, we're worried about them not being able to sort of maintain their own homeostasis, right? Being able to breathe on their own, being able to have their heart beat on their own, those types of things. So I want to be clear about that in terms of that tentorial plate, of what you might see clinically depending on where that injury lies, geographically speaking. Does that make sense? Okay. All right. All right. And in terms of discussing alterations, there really are different reasons for why someone might have an alteration, neurologically speaking. Metabolically, obviously, there are a lot of issues that could cause an injury somewhere on that divide. Obviously, metabolic things include like hypoxia, so lack of oxygen, lack of blood getting to the brain. Electrolyte disturbances can cause issues, hypoglycemia, drugs, obviously, drug overdoses, toxic kind of things to the brain. And when we're talking about some sort of metabolic reason for an alteration, we really can range on a wide continuum, from literally sort of slight drowsiness, maybe a little bit harder to sort of awaken or arouse, to all the way to coma, right? And to be clear, what I mean by coma is that really I mean a state of prolonged unconsciousness that can truly be caused by a variety of different problems or different disorders. And the reason I want to sort of make that clear, clinically speaking, about what my definition really is of coma is because I think, we see a lot of comas in just sort of, pop culture and soap operas and whatnot. So what I mean by coma is not that someone can come, it seems as if on movies and, ridiculous TV shows that people can just kind of come in and out of a coma at will, right, whenever there needs to be a dramatic scene. But that's truly not what a coma really is. It really is a prolonged unconsciousness that is due to some type of damage, usually metabolically, to that brain tissue. And we're going to talk more about that specifically in just a second. Also, there can be, and we're not going to spend a lot of time on this, but there can be sort of psychogenic reasons for some sort of alteration in arousal that is very uncommon, but I just wanted to sort of bring it up that despite apparent unconsciousness or apparent lack of being aroused, there are some sort of psychosomatic, more psychogenic reasons for why someone might appear to not be arousable. Where, in fact, for psychogenic reasons, the person actually is physiologically awake. So that if you would literally hook up like an EEG to their brain activity actually in their brain looks like they're awake. But they're acting like I shouldn't say they're acting, I'm not saying they're faking it. But there's some sort of psychosomatic, psychogenic reason for their lack of arousal. It obviously signals some type of psychiatric or psychosomatic disorder. We're not going to spend a lot of time about that today. What we really will be focusing more today on is either metabolic reasons for alterations in arousal or, 2 slides ago, more structural reasons for alterations in arousal. Okay? So let's talk a little bit more specifically about what this means clinically and what these sort of terms, coma and lack of arousal sort of means to us as clinicians and what we may see in our patients with some type of, neurogenic defect that's causing this. Okay, so again, coma. What does this mean? It's not, what we think of when we think of a movie or a soap opera. What I mean by coma is that truly, in the real world, clinically speaking, comas very seldom last longer than a couple of weeks. Patients who are unconscious or not arousable for longer than that period, or shall I say for a longer period of time than several weeks, may transition to a stage that I kind of already discussed briefly this morning, and that is something called a persistent vegetative state. We're going to talk about that in just a second. But depending on the cause of the coma, whether it's a structural problem or whether there's some sort of metabolic reason for these things, people who are in a persistent vegetative state for really more than a year are really extremely unlikely to awaken. And what I mean by awaken is that they're really not going to just sort of wake up from a coma if they've been in a coma longer than a year and be the same person that they were prior to whatever injury it may be. So I'm not saying that it's not possible for people who have been in this sort of depressed, sort of arousable state for greater than 12 months won't become more arousable and open their eyes and, that sort of thing, be awake. But if they do wake up from some sort of coma from a long period of time, they're usually not going to be the same person they were prior to the injury. So they will have sort of usually major sort of neurologic deficits post some type of, long-term alteration in arousal. And you see here on the screen what are some reasons specifically for why someone might have a depressed or an alteration in their arousal. Usually when someone has a coma, it's because there's bilateral, so both hemispheres have been some sort of damage to both of them or suppressed. Also, you'll see comas in brainstem lesions. And again, why would you see decreased arousal or decreased wakefulness in a brainstem injury? Because that's what it's in charge of, right? The brainstem is in charge of that wakeful state. That reticular activating system and brainstem are responsible for us being able to sit upright and be awake in these chairs this morning, right? So obviously, if you've got an injury to that area, you're not going to be awake, right? You'll be in a coma. So brainstem lesions or some sort of metabolic reason to the brainstem, or anything that sort of damages or suppresses the reticular activating system would lead to coma. Okay, let's talk clinically, though, about some specific things that we may see in our patients with some type of alteration in arousal. Again, because there's probably something going on to both hemispheres or to that brainstem or reticular activating system. So what does that look like? What do we actually see in our patients? Well, obviously, you're going to see a change in the level of consciousness, right? And I have that starred and very first thing on the list here. You're obviously going to see a change in their level of consciousness. And truly, the level or the extent, shall I say, of the change in the level of their consciousness is one of the most critical clinical indexes of how is this person going to do? What is their prognosis? So it really does indicate whether this patient may improve neurologically or whether, what you're seeing is more permanent. So it really can be a good sort of defining sort of prognosis of the individual's condition is the degree of their level of consciousness change when you're talking about alterations in arousal. Another really good clinical indicator that there has been some type of damage done either to the brainstem or to the reticular activating system is the way they breathe, pattern of breathing. So again, normally functioning, whenever all of us have a sort of hopefully well-engaged, healthy forebrain, specifically cerebrum, we have a very rhythmic type of pattern of breathing, right? It's very sort of higher level type of breathing, very rhythmic because we've got a healthy, intact cerebrum, right? Let's say we've had some type of injury to the cerebrum, okay? So that higher level of functioning, the higher level of control is wiped out, gone. But let's say the brainstem and reticular activating system is still intact. Okay, so now we're talking about the brainstem and the reticular activating system maybe not being damaged. Maybe it's the higher levels of the brain that's been damaged. You can still breathe, but you're going to have more of a primitive type of respiratory sort of rate and pattern. And what this is sort of called when you have more of this brainstem control of your breathing is something called post-hyperventilation apnea. So again, under normal circumstances, we have this very normal rhythmic pattern of breathing. With brainstem control of breathing, our breathing is very much tied to our level of CO2 in the brain. And so what I mean by that is, we talked about this a little bit on Thursday, that when you've got this mounting level of CO2 in the brain, the primitive way of breathing and the primitive way in which the brainstem will breathe for you, or tell you to breathe, shall I say, is that as the CO2 rises and they sense the increased CO2, your body says, oh no, we know that CO2 is toxic. We know that this is not, healthy for the tissue. And it will then stimulate the patient to take these big, deep breaths after being apneic for a while, right? So the person's apneic, there's no breaths, CO2 is mounting as someone is not breathing. All of a sudden, the brainstem realizes, oh, CO2 levels are way too high right now, and it stimulates the patient to take a breath. To breathe off that excess CO2 and to bring in some of that obvious, good oxygen that needs to sort of maintain the adequate metabolism of the brain, right? So that's what we call post-hyperventilation apnea. So you're apneic, then the brainstem senses an increase in CO2. It signals the patient to take some deep breaths in to blow off that CO2 and get in some oxygen. And then once that CO2 level has dropped and there's adequate levels of oxygen again, then the patient's apneic again. Then CO2 builds up. Brainstem says, oh, nope, too much CO2. Breathe that CO2 off, get some oxygen in. And so that's the cycle in which someone breathes with only brainstem control of breath. So it literally looks like this. They're apneic. And so it's this chain of hyperventilation, apnea. Hyperventilation, apnea. And a good, one sort of name for this type of breathing is Cheyne-Stokes respiration. Has anyone heard of this? Yeah. And that's exactly because you see these alternating periods of tachypnea and then apnea, all controlled by that mounting level of CO2 in the brain. So that's a really good indicator, or clinical manifestation of some type of alterations in arousal as well, is the way that they're breathing, because it's the control of who's controlling it, or whether or not they're breathing more normally and rhythmic, or they have this post-hyperventilation apnea. Does that make sense? Okay. Another really big indicator is pupillary changes, and I'm sure you sort of know this already, right? And that pupils and the way that they respond and react to light also indicate the presence or the level of brainstem dysfunction. And I've got a slide coming up with that in just a second to sort of illustrate that more specifically. Another really good clinical manifestation is oculomotor responses. So you'll see the way that the eyes sort of move and the way that the eyes track really change at various levels of brain dysfunction or brain injury as well. And again, I have a good slide for that coming up. And then motor responses of not the eyes, but the actual whole body. There are some pathologic reflexes that our body does with some type of brain injury, and we'll talk about those specifically in just a second. And then not quite as common, but I just put this up here on the screen just to kind of make you aware of it, that you also can see some other really weird sort of symptomatology in alterations in arousal with patients that have some type of decreased level of consciousness. And that could be some sort of abnormal sort of pathologic vomiting, yawning, and hiccups, actually. And a lot of, all three of these things can may be due to some sort of compression or disease process or increased pressure involving tissues of the medulla. So just kind of an interesting little side note there as well. But again, just wanted to sort of mention those to you. All right. All right. So here is the slide regarding pupillary changes at different levels of consciousness. Now, the two that we're really going to focus on for our purposes of this class today is these two right here. Restricted or pinpoint pupils, and then this one here where we're talking about more sluggish, dilated, and fixed pupil. Anyone know why you may see pinpoint pupils in a patient? Or where they're like literally teeny tiny little they look like the size of a pinpoint. Really small, constricted pupils. Anyone know why you may see that, clinically speaking, in a patient, if you were to actually look at ocular, pupillary changes? Anyone know? Yeah, Don. Opioids, right. An opioid overdose is a very, very good reason for why you may see pinpoint pupils. Literally, barely can even see the pupil. They are so small. Very good. Very sort of expected, shall I say, pupillary change with opioid overdose. Okay? Now, how about this one? This sluggish, dilated, and fixed pupil, usually bilateral. Okay, so you see here, and it might be kind of hard to see, but this, and I'll point to it on the screen here for purposes of the recording, but this pupil is extremely dilated, and oftentimes it's fixed. What do I mean by fixed? Doesn't react to light, doesn't accommodate and react to light, right? As opposed to this pupil might look pretty normal, right? What would cause this bilateral sort of dilated fixed pupil? Anyone know why that might be? Say it again, louder. Stroke. And even more general than stroke, anyone know why? Hypoxia, for any reason. So obviously a stroke would, be hypoxic because of lack of blood flow to the brain. Also, some type of edema or traumatic brain injury that's causing a lack of blood or a lack of oxygen getting to the brain would also cause that. So oftentimes clinically we refer to this dilated fixed pupil as a blown pupil. And again, not a good indicator, right? There's some type of pretty extensive hypoxic injury going on to the brain tissue for you to see this clinically in a patient. And the reason that you see this is because the brainstem areas that control arousal are also pretty close and adjacent to the areas that control pupils. So if you see some type of different level of consciousness or different level of arousal, you're probably going to also see some type of pupillary change as well. And that's because they're very close to each other. Those centers are very close to each other in the brainstem areas. Yeah? No, it does not mean that they're blind. And oftentimes in these types of patients, they're going to be unconscious. So you're literally not seeing these pupillary changes unless you're actually sort of manually opening up their eyes and checking their pupils. So it doesn't have anything to do really with their level of sensory or their level of being able to see. It just has everything to do with their pupils not reacting appropriately to light because of the damage so whatever damage has occurred in their brainstem is very close to that area that also controls pupillary changes and sort of normal accommodation of pupils. So that's why you're seeing that. It doesn't really have anything to do with their vision. Does that make sense? Okay. All right. So again, really good indicator of different levels of consciousness. Again, do not like to see this. Not a good prognosis of, unilateral blown pupil. Definitely a sign of pretty significant hypoxia to the brain. Here's another, so this is the example of some of those oculomotor changes or oculomotor responses that I talked about on that previous slide. Let's talk through this a little bit. So this test is often referred to as the doll's eye test. And that is because, you think of like a baby doll that has those eyes that sort of open and close and roll around in its head, right? If you move the doll, where you lay the doll down, the eyes kind of stay in the same spot, but the eyes open and close depending on how you move that doll's head. Some of them, even if you would like move the head to the left, the eyes would still stay to the right, right? You know what I mean? So that's actually normal, right? That's how our normal oculomotor response should be. If you move my head to the left, my eyes will probably still stay tracking forward, right? So if you move my head, I'm still looking forward, right? Move my head this way, I'm still looking forward. That's a normal oculomotor response. And that's what you're seeing here in A. They're, again, manually opening up this man's eyes, and as they're moving his head, his eyes are still staying forward. His eyes are still tracking. That's a normal oculomotor response. In B, what you see, and so the eyes turn together, right? They're conjugate in A. They're moving together in a sort of a manner that makes sense. They're conjugately moving together. In B, what you're seeing is as they move this patient's head to the left, his eyes maybe move, but they're not moving conjugately, right? So you see here that they're kind of like crisscrossed, they're, cross-eyed, or maybe even sort of tracking out laterally, disconjugately of each other. So B would obviously be an abnormal oculomotor response. So they don't turn in a conjugate manner together. This obviously would indicate some type of brain injury, right? When the eyes don't track together and they sort of track disconjugately from each other, okay? Significant injury there. That would be a sign of significant injury. C is probably even your most worst prognosis, in that as you turn this patient's head, his eyes do not track at all. So as you move his head to the left, his eyes go to the left. As you move his eyes to the right, or his head to the right, his eyes go to the right. They just stay fixed with his head, right? That's not a normal response for our eyes to do. So this is, the eyes move in the direction of the head, and this is a probably worse prognosis because this shows some type of usually brainstem injury. So again, the reason I'm telling you about these is that clinically speaking, we can actually kind of get a good idea in terms of the level of damage or the level of the type of brain injury that they have, depending on how their eyes respond, depending on how they actually look in doing this oculomotor response test. Yeah?
So would some of these conditions be like a basic skull fracture?
Yes, could be. Could be. Especially with the basilar skull fracture, we are worried more about brainstem injury, which you might see more in terms of the C response that you see in C. Yeah. Okay. Another really good sort of test, oculomotor reflex, is this test here. This is the ice water test. So in this test, they literally would use like a big syringe, like a 30 cc syringe, and actually take ice water and inject it into the ear canal. No thank you, right? That sounds awful. Normally, a normal response for this oculovestibular reflex would be that if you would shoot ice water into any of our ear canals, not only would the person get slapped who's doing it, but on a more sort of primitive level, our eyes will normally track to that noxious stimuli, right? Our eyes are going to look toward that ice water being shot into our ear canal. Sounds awful. So normal response is A, right, that you see right here. Conjugate eye movement toward that noxious stimuli. Okay? B, as you see them inserting and injecting ice water into this ear canal, the eyes move, well, I should say one of the eyes moves, but in a very sort of disconjugate way. It doesn't make sense. So one eye is staying forward, the other one kind of tracks outward, right? That would be an abnormal oculomotor response, which would, again, show some type of injury to the brain. And then again, perhaps worse prognosis is C, in that there really is absence of any type of response. There really is no eye movement at all when injection of the water in the ear canal occurs. Again, showing you sort of levels of dysfunction, right? Levels of damage to whatever, or for whatever type of damage has been done to the brain. So good indicators of prognosis and sort of level of injury. Okay. Another really good sort of indicator of some type of neurologic dysfunction or injury is pathologic posturing. So now we're talking about the way that the entire body sort of it's a brainstem reflex of how the entire body sort of responds to noxious stimuli when there's some type of brain injury going on. So that is this concept of pathologic posturing. And again, it's pathologic brainstem reflux of a patient who's had some type of traumatic brain injury to noxious stimuli. And the body of a patient who has some type of brain injury may respond in one of two ways when experiencing some type of noxious stimuli. And what I mean by noxious stimuli is I've had patients come in with some type of traumatic brain injury, and I'm literally trying to get an IV in their arm or get a Foley catheter into their bladder, and I start to see these abnormal sort of brainstem reflexes or this pathologic posturing in just that type of stimuli, insertion of an IV or insertion of a Foley catheter. And there's two types, decorticate posturing or decorticate rigidity and decerebrate posturing. Okay, so let's talk a little bit about what these two are. So decorticate rigidity is when, again, upon some type of noxious stimuli, maybe me trying to put an IV in their arm, they actually have this flexion type of reflex where their arms, again, this person may be unconscious, right? But even while they're unconscious, their arms come up and they flex their arms up into their core. That is called decorticate rigidity or decorticate posturing. It's a flexion reflex. They draw their arms up toward their core, And it usually shows some type, probably due to some type of either cervical spinal tract or cerebral hemisphere injury. So it could be a bleed, it could be even a concussion, but it shows usually some type of injury to the cervical spinal tract or cerebral hemisphere when you see that flexion reflex, that decorticate rigidity. So their arms usually come into their core, and as you see here on the picture, their legs kind of extend out and kind of get stiff and sort of extend out, but their arms come up. That is decorticate rigidity. Now, the other type of pathologic posturing you may see is decerebrate rigidity. And again, the corticate I sort of remember is decorticate, arms come into the core. That's how I remember it. Decerebrate is more of an extensor reflex, where the person, as you see here, sort of throws their head back, their arms get extended, their legs get extended, and it's more of an extensor kind of reflex. This usually is more of a serious injury, showing probably some type of injury to the midbrain and the pons. So again, more of a brainstem injury, and usually more serious. But either way, both of these types of pathologic posturing usually occur and sort of is a sign of some type of damage to nerve pathways that's sort of communicating between the brain and the spinal cord. It's showing some type of interruption in that signaling. Yeah. Usually decerebrate. Yeah, because that's decerebrate you're going to see more likely in terms of some type of brainstem injury and more cerebral, cerebrum injury with decorticate. Yeah.
Upon discovering this,
Yeah.
something that you would want to get that information to the doctor immediately, or?
Yeah, and usually this is going to be like a trauma kind of patient anyway, where everyone's in there together. And especially if you know that the specific trauma for this patient is a head injury, it honestly may not be that surprising to see it. So in instances where I've seen this, it may be a traumatic car accident, or even I've seen it in like gunshot wounds to the head, where you'll start to see them do that as you're trying to as you're all working as a team. It's not that unexpected. I mean, we're all sort of seeing it. We're like, well, yeah, that makes sense that we're seeing that. Yeah, exactly. And when I say rigidity too, I don't mean that like I couldn't just take their hand and push it right back down. I can. I mean, it's not like they're like stuck like that. It's just this sort of reflex that you sort of see. You can take their hand and push it right back down. It's not like they're stuck like that. So again, it's just sort of a pathologic reflex showing some side of damage or at least some type of interruption between the signals between the brain and the spinal cord. Again, I'll admit I'm kind of a patho nerd, right? But I've even seen this like when I'm watching like football on TV, right? A college game or an NFL game. If you've ever noticed sometimes when you have those like really nasty hits where it's like helmet to helmet content, you can tell before the player has even like hit the field that they're out. Have you ever, you know what I'm saying? Where you can sort of see as they're falling to the ground, they're not awake. It's maybe a concussion, maybe some other type of disruption in the activity of their brain. And then I've also seen that as they're on the field, haven't you ever noticed they're like in some sort of weird, like their arms maybe sort of come up, or they're kind of like laying there like this? That is pathologic posturing. It makes me sick, right? I'm like, oh God, that's not good to see. And in fact, I've got a kind of nauseating video for you.
Oregon State.
So watch this guy's posture. He's out. He's unconscious. Look at his posture. That's decerebrate or decorticate? Decerebrate. Watch it in slow-mo. Boom. Hit his head. He's out. Look at his posture. Right? So pretty nauseous.
Some freak injuries over the course of his career.
That's enough. How many times do they have to keep showing that, right? Now, I will tell you that and it really, I think it had to do with the fact of how he hit his head on the field when he hit, but he immediately went into that decerebrate sort of posturing. It turns out I don't want to say it was just a concussion, but it was due to a concussion. So the fact that he had decerebrate versus decorticate posturing is a little bit surprising to me. That a concussion usually is more some type of disruption in the cerebral area. But that's just an awesome, for lack of a better word, really good example, right, of pathologic posturing because of some type of interruption to the brain. So hopefully that'll sort of stick in your mind in terms of those pathologic reflexes.
Are there concussions to that mid-brain
No, honestly, because if you would have some type of really severe interruption to the brainstem, you're going to see way more problems than just a momentary loss of consciousness, right? Yeah, you're going to see issues with homeostatic kind of things, respiratory drive, heart rate, those types of things. So this guy ended up being okay. He was totally functional again. He's, normal person. But I just wanted to show you that in terms of that pathologic posturing. Okay. Yeah. Little bit different, because in that, like in a tonic-clonic seizure, which we'll talk about in a little bit today, they are very rigid. Like it's hard to move their arm from that position. As opposed to this, it's almost just like a reflex. Like you can push it right back down. They're not held, rigidly in that position. So a little bit different. But good question. Very, very good question. Yes. Sometimes, yeah. In fact, if I'm continuing to still try to find that vein, it might come right back up when I'm trying. So sometimes it's a matter of just needing to hold it down. Yeah. It's not going to stop doing it because that noxious stimuli is still there and the injury is still there. Yeah. Mm-hmm. Yes. 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 Yeah, and that was kind of the question that he had here. Is it kind of the same pathway? Yes, exactly. But two separate kind of things. And we'll talk a little bit more about seizures and what you see in that coming up. Yeah. Okay, so that's kind of the end of our discussion regarding sort of clinical manifestations of some, alteration in wakefulness or of arousal. But when discussing the ability to sort of stay awake or be awake, we really have to also talk about the level of injury to the brain. And shall I say, let's put it this way, outcomes of alteration in arousal really depend on the extent of injury, the extent of damage. Some individuals may recover completely from some type of change in their arousal. Like I said, just like this player on the football field, he came to and was completely normal, obviously had probably some post-concussive symptoms for a while, but was completely normal functioning person, right? But it really can range on a scale from being totally normal, going back to your baseline, neurologically speaking, to regaining consciousness, but maybe having some permanent disability, to never really regaining consciousness or wakefulness again, and experiencing what we would refer to as neurologic death. And when talking on on that spectrum of what you may see in terms of level of consciousness, in talking about this sort of neurologic death, there really are two forms of the most severe end of the spectrum. And that would be total brain death and what we would refer to as cerebral death. So there's two different things. So brain death and cerebral death. And I remember when I first kind of started taking care of neurologic patients, I was very confused as to the difference. What's the difference between total brain death and cerebral death? So let's talk about it. So total brain death occurs, so this is the first type, right? This is the first type of brain death. Occurs when the brain is damaged so completely that it really can never recover and cannot maintain the body's internal homeostasis. And so that's what I mean by cannot breathe on their own, cannot maintain their own sort of cardiovascular function on their own. So they're in an unresponsive coma, so there's absence of any type of motor and reflex response. So this is when you're seeing some of those ocular motor things that we talked about, like their eyes aren't responding at all. Their eyes aren't tracking, they're just staying fixed with the head, they're not responding to the ice water test. You also see no spontaneous respiration, so they're completely apneic. When doing sort of looking at electrical activity of the brain in EEG, you'll see no activity on the EEG, so a flat EEG for longer than 6 to 12 hours. So it's sustained. You're continuing after hours and hours of not seeing any electrical activity in the brain. You'll also want to make sure that you're not seeing electrical activity in the brain because for other reasons. So you want to make sure that they're not hypothermic. So they have a decreased core body temperature. And you'll also want to make sure that they haven't ingested, obviously, or overdosed on some type of depressant medication. Because actually those two things, both hypothermia and some type of overdose on some type of depressants can actually make the EEG look flat, right? Even though they may not actually have total brain death. Again, it sounds sort of insensitive, but a term that we say a lot in the ER is a patient's not dead until they're warm and dead, right? And I honestly mean that because there's instances of people who are hypothermic who have decreased cardiovascular response and decreased neural responses that when you bring their core body temperature back up, those things kind of start to function again. So hypothermia can actually depress some of those systems, and you want to make sure that obviously this person is brought back up to normal temperature before you sort of declare total brain death. You'd also obviously want to make sure that all completion of appropriate and sort of therapeutic procedures have been tried and have been done before you can really sort of declare total brain death. But again, total brain death means that the whole structure of the brain is not functioning and cannot sustain life. Does not have the patient breathe on their own, does not have the patient maintain cardiovascular function on their own. That is total brain death. Okay? As opposed to cerebral death. Now, cerebral death means basically just death of the cerebrum. So if you've got death and sort of, wiped out the function of the cerebrum, will the actual body of the patient necessarily die? No. Why? Why not? Because their brainstem may still be intact, right? So in someone with just death of the cerebrum, not the whole brain, you'll see death of the cerebral hemisphere, but exclusive of things like the brainstem and the cerebellum. So the brain can continue to still maintain that internal homeostasis. The person may still be able to breathe, maintain cardiovascular functioning, maintain temperature control, maintain sort of metabolic function, cellularly speaking, of the body, but the higher level functioning of the brain is not there. So in these patients, brain damage usually is permanent. So the cerebral damage is usually permanent. And the individual really is sort of forever unable to respond behaviorally, normally to the environment around themselves, even though they may still be able to breathe on their own and their heart's still beating and they're able to maintain metabolic and sort of temperature control and things like that. So they lose higher level brain functioning, like executive functioning, but the body can still survive because the brainstem is still intact. Does the difference between whole brain death and cerebral brain death make sense? Okay, yeah. With this type of patient? Good question. We're going to actually get into that because there's actually some levels of cerebral death. So let's talk about that because we could have an entire semester on ethical discussions regarding this type of patient. Like the Terry Schiavo case from several years ago, and there's been several other cases in the news regarding this. And those are the types of patients that you would say have cerebral death. Exactly. So let's talk a little bit about the levels, so to speak, of cerebral death. Okay, so what I want to be clear about is that a patient, can survive cerebral death, right? And there is sort of a continuum, as I just mentioned, of what a patient may look like after they have quote-unquote survived cerebral death. So the first option is, and sort of the worst case scenario of cerebral death, is that they completely remain in a coma forever, right? Eyes are closed. There's no sort of automatic opening of the eyes. They don't follow commands. They don't speak on their own. They have sort of no voluntary movement, no voluntary control. That is sort of the sort of most basic, most worst case scenario, worst prognosis of someone who has survived cerebral death. But people can stay that way forever, on a ventilator. I shouldn't, actually, not even on a ventilator. Why did I say that? Because their brain is able to sort of maintain themselves. And that is where you start getting into these ethical issues of, is that really living, right? And then you start to get into all of those, what do you do with these types of patients? What does the family want? What would the patient have wanted, et cetera, et cetera. However, there is a possibility to sort of emerge from that most basic coma. Some people may never, but there is a possibility of some people sort of emerging from that. And then you get into something called a persistent vegetative state. So if you want to think of it like as the next step up, the next step improvement over a coma is a persistent vegetative state. So we still have complete unawareness of self and environment, complete loss of more of those sort of higher level executive cognitive functioning. Usually don't speak, don't follow commands, aren't part of their environment. However, they may be able to open their eyes spontaneously, and they may still have pretty normal sleep-wake cycles, okay? The brainstem reflexes are present, but oftentimes you won't see, ability to sort of control bowel or bladder continence. Now, again, talking about ethical issues, obviously you can imagine as a clinician, if you know what a clinical, sort of presentation of a persistent vegetative state is, it can be very difficult to family members at the bedside who are clinging on to any hope, any possible glimmer of improvement when they start to see eyes open, right? Or they start to see more of a normal sleep-wake cycle. It can be very difficult as a clinician to have those difficult conversations with what this actually means. That just because this patient's eyes are open does not mean they're understanding what's going on around them, does not mean they're going to be able to interact with you or interact with their environment. So again, understanding the levels, basically, of cerebral death can be very important, but also very difficult as a clinician to really sort of make that clear to these family members who are clinging for any sign of life, so to speak. So again, a persistent vegetative state is sort of your next step up or next step better from coma. Then you can actually go even one step higher than that. Yeah.
With the complete unawareness thing, is there any research or evidence that, so they're not aware in our perception of awareness and how we kind of define awareness, but
How do we know?
how do we know?
Because they can't respond to their environment. EEG, actual testing, actual diagnostic, and yeah. The level of activity going on in their brain, the level of actual neurons synapsing and working. Yeah, you can actually, clinically see that. Yeah. But you can even sort of improve one step even above a persistent vegetative state, and that is progress into something called a minimally conscious state. So this is a patient who may be able to sort of follow simple commands, may be able to sort of manipulate objects that you would set on their tray table in front of them, may be able to give yes or no responses, maybe verbally or maybe just being able to sort of, blink twice for yes, blink once for no kind of thing. They may have intelligible speech. They may, blinking and smiling and sort of interacting with people around them. But they may not necessarily be the same person they were prior to the injury, okay? So again, they probably they don't have higher level executive functioning. These are not the patients that will be able to sort of live by themselves again, or drive a car, or hold down a job, or be in a relationship, right? They are not the same people that they were prior to the injury, or the stroke, or whatever it was that caused this death to the cerebral tissue in the first place. So again, you've got coma, persistent vegetative state, and then minimally conscious state. Again, but these are not your norm. These people will never be sort of normal again. And again, that's really hard to have that conversation with families, right? That yes, they're answering questions, and they may sort of be around you and understanding what's going on and being able to sort of interact a little bit. But, this is not the guy who's going to get to go back to his work as an attorney, right? This is not the person who's going to be able to drive that excavator on the construction site, right? So again, it can still be very devastating because they are not the same people that they used to be. And so that's kind of the sort of the best prognosis, so to speak, of cerebral death. Then the next thing I have on this slide is something called locked-in syndrome, which I really don't want you to sort of lump into these other sort of stages that we just talked about, but I do need to mention it. I do need to talk about it for a little bit. Locked-in syndrome is something that occurs, again, because of some type of damage to the cerebrum, to the brain, but usually is specifically due to damage to the efferent pathways. And so what I mean by that is they cannot communicate effectively through speech or body movement or voluntary sort of, control. So this is devastating. Because what this essentially says is that the afferent pathways are intact, so their sensory is completely intact. They know what's going on around them. They can feel hot. They can feel cold. They can feel pressure. They know what's going on in their environment because their afferent pathways, their sensory pathways are completely intact. But their efferent pathways, the ability to sort of answer that and respond to that, is completely wiped out. So they have complete paralysis of voluntary muscles with exception oftentimes of like eye movement. So they can, again, blink to respond and that type of thing. The content of thought and level of arousal and the level of sensory, being able to take in their sensory environment is completely intact. They just, and fully intact, oftentimes cognitive function. They just can't, they have no control over getting that information out to you, out to the environment. So again, pretty rare. But certainly is something that you may see with, again, specific damage to the efferent pathways that we talked about previously. So I just wanted to sort of quickly mention that. It's its own little category. All right. Okay, so that's really the end of our discussion regarding alterations of arousal. Very quickly, we'll talk a little bit about alterations in awareness before we get more into sort of cerebral hemodynamics and more, functioning of the brain. So alterations in awareness pathophysiologically can happen because of direct destruction by some type of ischemic or hypoxic problem, or because of effects, like I was mentioning already, of some sort of toxin or drug or overdose or something like that. But a little bit different. You don't see this near as often in sort of like a traumatic kind of situation like you do with some of the other things we talked about in terms of alterations in arousal. So some of the things that you actually may see because of alterations in awareness would be things like selective attention problems and more of executive attention problems. So selective attention defects or deficits is really the ability to selective attention is the ability to select from available sort of competing environmental and stimuli, right? The fact that we can sit in here and sort of be able to weed out what's important and weed out what's not important and sort of make sense of our environment is selective attention. So if you've got a selective attention deficit, again, pretty rare, but oftentimes what may cause this is, either permanent or maybe more temporary issues like seizure activity, some sort of parietal lobe bonk, some sort of contusion to the parietal lobe, hematomas, strokes, things like that. In fact, you might actually see some of this selective attention deficit in like stroke patients as they're recovering, like in long-term rehab hospitals with patients who have had some sort of CVA. You may see issues with those types of patients really being able to weed out the external stimuli and really be able to make sense of their environment. And then really another example of an executive attention deficit is indeed attention deficit hyperactivity disorder, right? ADHD. Again, the inability to sort of maintain and sustain attention. So again, what that really says to you is that maybe there is something going on with people who suffer from ADHD in terms of their level of ability to sort of be aware, right? And to sort of executively be able to sort of attend to things in their environment. So again, this is the alterations in awareness are a little bit different than the alterations in arousal that we just got done talking about, in that it may not necessarily be because of traumatic injury to the brain, but there obviously is some sort of defect going on in the brain to cause either selective or executive attention deficit. So I just wanted to kind of briefly mention that today as we discuss both awareness and arousal. Okay. Another really sort of interesting and clinically relevant type of alteration and awareness is issues with memory, so amnesia. So alterations in awareness that have to do with problems with memory would be amnesia, loss of memory. And there are really two types of amnesia. You can have retrograde amnesia and intergrade amnesia. Now, interestingly, you'll see retrograde amnesia for a lot of different reasons. Clinically speaking, I have seen a lot of that with patients that have had some type of head injury, like a concussion. And truly the definition of retrograde amnesia is that you have a patient who's experiencing loss of past personal history or past sort of factual memories. I have a good example of this. So long time ago when I was working in St. Louis, I had a guy who, it was Super Bowl Sunday, kind of perfect for this time of year, who was leading a Super Bowl party at his friend's house and fell out on the sidewalk, on, icy sidewalk, fell and really struck his head pretty hard on the sidewalk outside. So he came in because he had momentary loss of consciousness at the scene, and then now was awake, but was experiencing pretty profound retrograde amnesia. So he had no recollection of the entire day prior to the Super Bowl party. I mean, that whole day was lost. Didn't remember that morning, didn't remember going to the party, didn't remember who won the game, didn't remember any of that. And it turned out it was temporary because of a concussion, but he was pretty funny because I shouldn't say funny, it sounds insensitive, but it was interesting because he had not only sort of long-term past memory problems, in terms of the beginning of the day and that sort of thing, but he also had pretty short-term past amnesia as well, because he couldn't remember the things that he had just said to me or the things that we had already talked about in the ER. So when he first came in, he was sort of totally conversing and normal and able to sort of hold a conversation with me. And he asked me, I think my girlfriend was behind us in the ambulance. Can you make sure she knows what room I'm in? And can you make sure she knows where I am, that I'm okay and all of that? Can you give her a call? Here's her number. And I said, yep, let me give her a call. And so then I went on, about my work with him and came back in a couple of minutes later. And he's like, oh, yeah, so my girlfriend was at the party. And I think she was behind us in the ambulance. Would you be able to give her a call and let her know that I'm here and what room I'm in? Yes, I did, and she's on her way, So, I mean, literally 15 times he kept saying this, and I'm like, yes, dear, your girlfriend's on her way. She knows you're in room 8, everything, But he literally had that very short-term retrograde amnesia as well. So that's kind of the example of retrograde amnesia. And again, it can be pretty temporary, it can be pretty mild, and oftentimes you do see it quite commonly in concussion or post-concussive type symptoms. The other type of amnesia is interrograde amnesia. Now this is interesting because with interrograde amnesia, you still have retention of memory of events in the distant past, but you're really able, and this is pretty devastating, you're really unable to form new memories. New factual memories, new personal relationships, things like that. From that definition, can anyone give me an example of that? 51st dates, right, exactly. Adam Sandler and Drew Barrymore, right? She remembers her brother, remembers her life, remembers her dad, remembers her hobbies, that she was good at painting and art and that sort of thing. But poor Adam Sandler, she can't remember him for the life of her, right? That is sort of a silly example, but a very accurate example of interrograde amnesia. Okay, so again, that's also considered an alteration in awareness. The amnesia is certainly an alteration in awareness. Yeah? It is sort of. He almost kind of had both. He did. But the fact so he both kind of had retrograde and interrograde. But the fact is that he sort of remembered me, though. So every time I came back in the room, he knew I was his nurse. He knew my name. He remembered that he was in the ER and that I was taking care of him. So somehow it was this sort of selective short-term retrograde amnesia, that he knew where he was and he knew who I was. It wasn't like I had to keep introducing myself to him every time I came in the room, but he still could remember that he had asked me that question over and over and over again. Yeah? Yes, they both can. Absolutely they can. And they can sort of run on a continuum. So maybe as they neurologically improve, maybe their retrograde amnesia gets better. So for the instance of this guy, he wasn't going to always have retrograde amnesia. And even in the short time I saw him in the ER, it was getting better. Yeah, good question. Okay. All right. So that kind of concludes our discussion about alterations in awareness and arousal and awareness. Now I want to sort of move to a different conversation in terms of more big picture, sort of cerebral hemodynamics. And this really ties into that discussion that we were having last week regarding intracranial pressure and increased ICP. So let's talk a little bit about that here this morning. So we're sort of leaving that alterations of arousal and awareness and getting now into sort of the overall sort of hemodynamics of the brain and cerebrum more specifically. And so in that discussion, I need to sort of make several sort of terms clear to you as we move forward. The first thing I want to make sure that we're sort of on the same page of is cerebral blood flow. And what I really mean by that is just blood flow that's normally maintained at a rate that matches the needs, metabolically speaking, of the tissue in the brain, right? So the blood flow that's getting to the brain is adequate. It's what the brain needs. It's matching the need. Cerebral perfusion pressure, CPP, is pressure that's required basically to perfuse the cells of the brain. So the pressure that's needed in the arterioles in the brain to be able to get that blood out into the tissue and into those capillaries of the brain. Normal CPP should be about 70 to 90 millimeters of mercury. Now, if you would see a pressure higher than that, arterially speaking, what do you think is probably going to occur in the brain? Increased intracranial pressure, right? So that's why I want you to be clear about what that normally should be. Cerebral blood volume is truly just the amount of blood present in that intracranial vault, in that space at any given moment in time. And then cerebral oxygenation is basically just measured by the oxygen saturation of the internal jugular vein as that blood is leaving, right? We know that the IJ is sort of the vein, a big vein that sort of pulls the blood away from the brain. So they really measure that by looking at how much oxygen, sort of residual oxygen, is left in the IJ, and that's a pretty good indicator of how much oxygen got left, right, and diffused in those capillaries in the brain. So again, whatever oxygen is sort of left in the vein is a pretty good indicator of the oxygen that was left behind in those capillaries in the brain. And that's how they kind of can tell and sort of measure cerebral oxygenation. Okay, so in continuing our discussion about the pressure inside the head, you really have to sort of realize, right, that the cranium, unfortunately, for people who have increased intracranial pressure, is a rigid, fixed container, right? And that's unfortunate for people who are experiencing increased intracranial pressure or increased volume. So we know that the brain inside the skull, inside the cranium, takes up the most space, about 80%. And then the blood and the cerebral spinal fluid takes up about 10% each of the rest of that 100%. So an increase in the volume of any one of those components can certainly be accompanied by a compensation or a decrease in the other components, right? And unfortunately, for CSF's case, CSF is usually the one that sort of gets displaced or that tries to compensate first for an increase in brain tissue or an increase in blood flow to the head. So usually CSF is the most readily displaced in terms of trying to counteract that intracranial contents and that intracranial pressure. But all of these components, brain, blood, or CSF, exert a force within the cranium called intracranial pressure, ICP. Now, we obviously need a little bit of intracranial pressure, right? So normal ICP for a normal patient should be about 5 to 15 millimeters of mercury. And for all of us sitting in this room, hopefully it's about 5 to 15. The magic number that I kind of try to always remember when thinking about ICP is 12. Again, I find it just easier to think of one number than a range for a lot of these lab values and things like that. And so I sort of feel the same way about ICP. I try to think of it close to 12. If it's around 12, I feel pretty comfortable, right? And really, not until ICP climbs to about 20 or greater do we even start to see treatment necessary, right? Before we even sort of start therapeutic, activity. But obviously, ICP can be increased because of a lot of different reasons. Because maybe there's a tumor in there exerting increased pressure, because there's swelling because of a traumatic brain injury, so swelling or edema. You can see too much CSF, which would obviously cause too much pressure in the head, or bleeding, right? Hemorrhage of some sort. All of those things can cause increased pressure. And again, if we're seeing any of these things, tumor growth, edema, bleeding, whatever, in our arm, what happens? Our arm just gets bigger. It just swells. If you've got that type of swelling in this fixed space inside the cranium, we're in trouble. This patient is in major trouble in terms of neurologic deficit and neurologic decompensation. Okay. So clinically speaking, what do we actually see, right? There's stages of increased intracranial pressure. The first stage, so to speak, you really will just see sort of vasoconstriction and external compression of the venous system in the head. And this really does occur basically just to attempt to further decrease or sort of compensate for that intracranial pressure. So really in stage 1, if you were to actually measure intracranial pressure, you may not actually see an increase really that significantly in intracranial pressure, because in stage 1 you're seeing pretty effective compensatory mechanisms kicking in. So stage 1, you may not see that much of a change in ICP. Now, in stage 2, when you see continued and prolonged extension or expansion of that intracranial content, now we're going to start to see things kind of start to decompensate. So pressure begins to compromise neuronal oxygenation, and you'll also start to see systemic arterial vasoconstriction occurring sort of in stage 2 as well. So now you're going to start to see some symptoms. You're going to see some symptomatology because to overcome increased intracranial pressure, things kind of have to change, right? So you're going to see some systemic arterial vasoconstriction. You may see lack of blood flow to the head, etc. So this is in stage 2 when you're going to start to see sort of maybe those more subtle, sort of transient clinical manifestations of like changes in level of consciousness. So this is probably where you're going to start to see your patient become a little bit more confused, maybe a little drowsier, harder to wake up, maybe a little more just sort of restless. So, and by restless I mean just kind of, trying to get out of bed, trying to get up, trying to climb over the bed rails after you've told them like 23 times to get back in bed and please don't climb over the bed rails, that's not safe, et cetera, and they're just kind of continuing to do those sort of activities, that behavior. This is stage 2. We're going to start to see some of that level of consciousness change. Yeah?
Sorry, I'm not sure I understand why the venous system was first vasoconstricted.
Right. It's sort of a compensatory mechanism that basically, if you see systemic arterial vasoconstriction, you're also seeing arterial vasoconstriction to the head as well. And so it's sort of more of this like hemodynamic compensatory mechanism to try to decrease the volume of blood getting to the head because there's no room for that blood to get there. Does that sort of answer your question? Ish?
Venus, though, I don't think that. Why you would want to
Up here?
blow it out?
Oh, up here. Okay. So you're actually seeing compression of the venous system in the head. Here we're talking about systemic, but up here we're talking about venous system occurs in the head. You're seeing constriction of the veins.
So I guess in my mind I'm thinking if there's really just want to get some of that fluid out, and if the venous system is constricted, you're getting less fluid out.
Right. This is not actually happening because of sort of like a compensatory mechanism. This is sort of an effect of that swelling. You're actually compressing the venous system in the head. Sorry, I didn't understand what you were asking. Does that make more sense? Okay. Yeah, that's not occurring as a compensatory mechanism. It's happening because of the increased swelling in the head is actually pressing on those veins. Does that help? Okay. Good question. Sorry to confuse you. I wasn't sure of the question at first. Okay, so that's stage 1 and stage 2. Stage 3 is now when you actually start to see that ICP begin to climb. The pressure is actually starting to mount now. And so much so that it's actually almost as high as the arterial pressure of the arteries trying to get to the head. So what do you expect might, clinically or sort of physiologically speaking, if the pressure in the brain is reaching and sort of approaching the pressure of the arteries trying to get blood to the head, what are you going to start to see physiologically? Or shall I say pathophysiologically? Issues with perfusion, right? Issues of those arteries actually able to push through that pressure to deliver blood to the head. So the brain tissues start to become now hypoxic. They start to have lack of oxygen because the arteries can't overcome the pressure of the tissue itself to actually drop off and deliver that blood. So not only will you see hypoxia, you'll see lack of oxygen, but you'll also start to see hypercapnia. Anyone know what hypercapnia means? Increased CO2. Right? Because you're not getting that adequate sort of, perfusion and therefore sort of the exchange of oxygen and CO2 in that tissue at the capillary level. And now this is where you start to see the patient's condition pretty rapidly start to deteriorate. So now you're seeing a decreased level of arousal. You're starting to see bradycardia because it actually can cause some sort of cardiovascular changes as well. So you're seeing their heart rate kind of bottom out. This is also now where you're going to start to see those pupillary changes start to occur. So it would not be uncommon at all to see someone who's kind of in this stage 3 of increased intracranial pressure, of having those sluggish, fixed, maybe unilateral, fixed, sort of blown pupil. Again, because of that hypoxia that's going on in the brain tissue. Is your question? It can certainly cause a headache, but oftentimes it's also associated with decreased level of consciousness and unconsciousness, so they're not really complaining of a headache because this poor person's unconscious. But No, because the skull is fixed. So the outside of their head looks completely normal. All of this pressure is mounting up inside this small little cavity. Yeah, good question. And then you can progress even farther, stage 4, where there's so much pressure mounting up in this fixed vault, in this fixed container, that the brain tissue actually starts to shift, actually starts to get pushed inside of the skull. We call that herniation, or that the tissue has herniated. And so it herniates from the compartment of the greater pressure to the compartment of lesser pressure. So that's to say, if I've got a subdural bleed here on the right side, that blood mounting up and bleeding and causing this big sort of lesion inside my skull is obviously going to push that tissue that should be on the right side of my skull over, right? And it can get so bad that it actually pushes that tissue across the midline of the skull. Obviously, this is not good. This person's prognosis can be very poor, because obviously it impairs blood supply to the tissue that should normally occupy that space, and it also just pulls, right, on all of that tissue and those nerve cells and pushes it from one side of the brain to the other. We refer to that as herniation. Now, there's a lot of different sort of spaces in the brain that this herniation can sort of push brain tissue down into. It can actually push it down like sort of through the base of the skull down into sort of the brainstem area and to some other areas within the skull. We're not going to get into that here. These next couple of slides about sort of where or which direction the brain can get herniated is just kind of for your FYI. So these herniation syndromes. But what I do want to show you is the way this looks actually on radiographic studies. So this is a great CAT scan of an example of a midline shift or a herniation. So you see here, there's this very large extradural hematoma right here. So this white is all a collection of blood inside the skull, inside the intracranial vault. And as you can see here, it's pushing all this cerebral tissue over, right? These ventricles should be right here. They should be in the middle of right around midline, and they're getting pushed over here to this side of midline, to this side of the skull. Now, that's what D is showing. Now, E is actually post-surgery. So after craniectomy, where they've actually kind of opened the skull up and evacuated that blood, you can see now how after surgery, the brain tissue has kind of shifted back to where it should be, right? The ventricles look more midline. That big accumulation of blood is gone. And it looks more symmetric. It looks more midline, right? It's not so herniated and pushed over here. However, F shows you that about 4 months after surgery, that the brain, even though the blood was evacuated, the brain has sustained a pretty significant injury because of that swelling and because of that herniation. And you're actually seeing some actual cerebral tissue atrophy now in picture F. See how these ventricles are so large and kind of blown out and bigger than they should be? This is what the size the ventricles should be, right? Look how much larger, especially this one is. That's because there's actually been some tissue atrophy and some tissue death because of that trauma, because of that damage that the brain sustained when being pushed across midline, and because of that swelling in that tight skull area. So again, D, E, and F shows you sort of the progression of what may occur in the cerebral tissue with a midline shift and herniation, showing you more, on, CAT scan. So that's a really good visualization of that. All right. So, in discussing increased intracranial pressure, we want to kind of talk about some reasons. Okay, so we've talked about how much pressure should be. We've talked about the stages of increased intracranial pressure. But what clinically would actually cause it for our patients? Really, cerebral edema is a huge one. I mean, that hopefully is pretty obvious to you of why that would actually cause an increase in intracranial pressure. So an increase in the fluid content of the brain. So, reasons, trauma, right? Any kind of trauma, be it a bump to the head, be it a gunshot wound, be it whatever, is obviously going to cause tissue swelling, the same way it would cause tissue swelling in our arm or our leg or wherever it may be. Infection can also cause swelling, as we know, sort of that inflammatory processes. And then obviously other reasons here on the screen as well. Infarct, what do I mean by infarct? Lack of blood flow, lack of oxygen, right? Like a CVA kind of thing. Good. So any of these things can certainly lead to increased intracranial pressure. Types of cerebral edema, different reasons for why that may be. Maybe it's because of an increased permeability of the capillaries, just like for those more inflammatory reasons that we've talked about already, the seepage of fluid from the vessels out into the tissue. Cytotoxic reasons, so things that are obviously toxic to the brain, like we were talking about with the liver patient that had ammonia build up across that blood-brain barrier. That's obviously very toxic and would cause cerebral edema. And then interstitial reasons. So oftentimes when there's a movement of actual CSF, so cerebral spinal fluid, out of the ventricles and into that extracellular space, out into the tissue, that would obviously cause increased intracranial pressure as well. So hydrocephalus, the increased level of CSF, could obviously be a reason for cerebral edema or increased intracranial pressure as well. Okay. And then we'll just finish up here talking about hydrocephalus, and then we'll continue our discussion regarding some of these other reasons on Thursday. So hydrocephalus really just means that it's an excess of that cerebral spinal fluid within the cranial vault, within maybe the subarachnoid space, or both, right? And we know that CSF flow can be sort of interrupted by several different reasons, right? It can either be because there's decreased reabsorption occurring. Now remember what we talked about on Thursday was sort of the sole sort of structure that's responsible for reabsorption of CSF? Anybody remember? Those arachnoid villi, right? Those little pouches from the arachnoid space that actually reabsorb CSF. So it can be a decreased reabsorption problem. It can be that they're just, for one reason or another, this person is actually producing excess CSF, so an increased fluid production by itself. Or maybe there's some sort of obstruction with the actual ventricular system and with the flow of CSF that's actually sort of causing like a roadblock. So instead of the CSF sort of flowing through the ventricular system in the brain, there's a blockage somewhere of that ventricular system, and the CSF just builds up behind that blockage. So there's different reasons for why it might occur, but it all sort of causes the same problem, an increase of CSF in the ventricles that then may seep out into the cerebral tissue and obviously cause increased intracranial pressure. Really quickly here, there's a couple of different forms of hydrocephalus. The first type is non-communicating hydrocephalus. This is oftentimes due to an actual obstruction somewhere in the ventricular system. And this is the kind of hydrocephalus that you'll end up seeing more commonly in children, so in the pediatric population. And then communicating hydrocephalus is really due to that defective reabsorption of those arachnoid villi. And you'll see this more commonly in adults. And then acute hydrocephalus really is just the development very quickly over a short period of time, like a couple of hours, in patients who have sustained some type of head injury, where you have sort of leakage of CSF into that tissue that causes a pretty significant increased intracranial pressure. And then lastly, the last type of hydrocephalus is what we call normal pressure hydrocephalus. This actually causes the ventricles, with this increased CSF, the ventricles just sort of dilate and they accommodate, basically, that increased CSF. So the reason it's called normal pressure hydrocephalus is that it may not necessarily cause an increase in hydrocephalus, an increase in intracranial pressure, because the ventricles are sort of compensating. However, even though you may not have actual increased ICP with this type of hydrocephalus, you may see cognitive decline and cognitive issues with these types of patients. So declining memory and cognitive function, looking almost like a dementia kind of situation in these types of patients with hydrocephalus, this type of hydrocephalus. All right. And this is just a really great picture of these really enlarged ventricles. Look how big these ventricles are compared to like those other ventricles we saw on the other CAT scan, due to excessive CSF buildup. So just a really good picture of an MRI of hydrocephalus and the way the ventricles can really get blown out and dilated. Okay, so we will stop there and we'll pick up on Thursday with our discussion of seizures. Thanks, guys.